Hey everyone, so this is part 14 of Anesthesia series. Now we'll be discussing about a few points which are continuation of modes of mechanical ventilation. So weaning. So weaning is nothing but it is gradual reduction of patient to remove venti dependence. So we'll gradually remove venti dependence of patient and to breathe his own and to breathe by his own. So controlled ventilation is not suitable for weaning, whereas synchronous and pressure related ventilation they are useful for weaning. Now if it is less than 105 rapid shallow breathing index, if less than 105, then it is ready for weaning. Now rapid shallow breathing index will predict when weaning has to take place. Here we have a term called PEP, which is positive and expiratory pressure. So this is the amount of pressure remaining in the alveoli at the end of expiration. It is basically pressure, positive and expiratory pressure. So this is used to decrease CO, decrease ICP, and to avoid barotrauma, and it will also prevent collapse and increase recruitment and decrease work of breathing. So these are few points that are related to PEEP. So it will decrease CO, ICP, then barotrauma, and it will prevent collapse, increase recruitment, and decrease work of breathing. Now we have few goals that we have to or want to meet by mechanical ventilation. So these are, we want to achieve tidal volume of 6 to 8 ml per kg. Then we want a respiratory rate that is 16 to 18 beats per minute. Then FiO2 we want it to be 21 to 100%, and PEEP has to be greater than 5 centimeter H2O, and plateau pressure less than 30 centimeter H2O. So in ARDS, however, tidal volume can be 4 to 6 ml per kg, and PEEP is greater than 8 centimeter H2O. And these both are dependent upon ABG, like partial pressure of oxygen and partial pressure of CO2 are required for this. So these are goals of mechanical ventilation. Now we also have a graph here which you just have to memorize like that. So this is how it is. Yeah, so this is how it is. This is PEP, and then this is airway resistance, and this is compliance. This is the compliance of pulmonary thing, and this is the resistance of airway, resistance and compliance. So this is where this is where exhalation will begin. And this is where end inspiratory pause is seen. So there is drop in pressure as flow has stopped, and drop in alveolar volume is also seen. So we will be having resistance and compliance as a result. Now we will be starting with CPR. So before starting the CPR, we will see basics of CPR. So CPR means cardiopulmonary resuscitation. So one rule is push hard and push fast. So depth has to be 1/3 of AP diameter, which is approximately 2 to 2.5 inches, and the speed has to be 100 to 120 per minute. Then allow for chest recoil, which is a very important point, and rate of breathing in CPR. So in adults, in children, then neonates. So in adults, it is 10 beats per minute. In children, it is 20 to 30, and in neonates, it's 30 to 60 beats per minute. So 10, 20, 30, and then here 30 and 60. Now we will talk about adrenaline doses. So generally in anaphylactic shock or status asthmaticus, we'll be giving 1:1000 by IM or subcutaneous. Okay, this is very important. Now next, in cardiac arrest, we'll be giving 1:10,000 IV greater than interosseous, which is greater than intertracheal. Then in vasoconstriction, we'll be giving 1:1 lakh, and in local anesthesia, we'll be giving 1:2 lakh. Then we have labor, where we'll be giving 1:4 lakhs. Coming to a few more extra stuff. So amiodarone dose that is given is 300 mg initially, later on 150. And coming to dosage of lignocaine, we'll be giving 1 to 1.5, later half of it will be given. Now shock energy for defibrillator. So monophasic, biphasic. For monophasic, 360, for bi 120 to 200. So these are the shock energies. Now we'll be talking about post cardiac arrest care. Now coming to post cardiac arrest care. So first, we will have to optimize the circulation. Then we will have to optimize ventilation. Then we'll be controlling temperature. Then we'll be controlling glycemic control, and we'll be having coronary intervention and early prognostication will be done of the neurological outcomes. So this is about this. Now blood sugar has to be between 144 to 180 mg per deciliter, and in ventilation SpO2 has to be greater than 94%, and circulation mean arterial pressure has to be greater than 65 mm per Hg, and temperature has to be 32 to 36 for 24 hours for comatose patients. So these are the criteria that has to be met. Now there are reversible causes. So one more thing is interosseous, it is given for tibia, and reversible causes for cardiac arrest or this thing is, so we have 5H and 5D. So we have hypoxemia, then we have hypoglycemia, we have hypovolemia, then hypo or hyperkalemia, and we have H plus acids, and we have hypothermia. And for 5Ts we have thrombus, then we have toxins, tamponade. So thrombus we have pulmonary artery and coronary artery, then we have tension pneumothorax. So these are reversible causes.